can hear myself. Yeah? Everyone can hear me back there? Yeah, I know. Yeah. I want to go. Oh, there we go. It's actually not afternoon at all. My notes don't make sense. See? Good afternoon? No. Okay, everybody. Welcome back, and thank you for joining us for part 2 of our presentations. My name is Margaret Sari, and I'm a PhD candidate here at the Faculty of Nursing. Like Anne said, I am doing my work in home care as well, looking at service utilization patterns for dementia patients in the community. But I'm also the research manager for this study, and so many of you have communicated with me many times over the course of the last 2 years, and I really appreciate all of your communication. And yeah, so we're just going to go ahead. So in our first presentation this morning, Erin discussed some of the home care team member roles, some of the issues around communication and documentation, and really looked in depth at the PSW role. She also outlined the skills considered to be core to the PSW role and the added skills, which are transferred to PSWs, and some of the challenges to the safe integration of PSWs in home care. Now in this presentation, I am going to be covering the delivery of added skills, looking at some of the structures, documentation, service patterns, and continuity of care, and then I'm going to be providing some of the details of the outcome event rates and review some outcome reportings information. Like Erin said, at any time you can feel free to ask me questions if you need clarification. We'll try to hold discussion of any of the topics to the end of the presentation or to our discussion groups in the afternoon, but for sure if I'm saying anything that doesn't make sense, please just let me know. Okay, so first we're going to look at documentation. As was highlighted, the documentation takes place in multiple charts, which can be either electronic or paper-based. Often the charts aren't shared by providers, and there are some exceptions to that, such as the chart in the home for palliative patients, where everyone is able to see the charting and chart in the same paper-based chart in the home. But for the most part, that's not what is happening for the rest of our patients. So in this study, we considered the home care client record to consist of service provider charts along with administrative records. And together, these charts provide valuable information about the care received by clients in the community. While the contents and forms may vary by organization, a typical nursing chart looks like this. It has client consent forms, care plans, flow sheets, and progress notes. And so flow sheets are really to document information about specific care like wound care, IV care, dialysis, and the progress notes are where nurses can document their assessments and any other information that they feel is really important for the patient care. The personal support charts, again, have client consent forms, care plans, tick sheets, and teaching agreements, and they're a little bit more task focused. And so we're going to come back to teaching agreements a little bit later on in the presentation, but yeah, those are the basic things that we saw in most of the charts. And so for our purposes, the administrative charts that we're talking about is the CCAC chart, the CRIS record, and the service provider chart administrative record pieces. So in some places there were face sheets and the referrals and any service updates that the CCAC would send through. A lot of that stuff got printed out and put into the charts in the agencies. So in this slide, I have laid out basically how these provider records relate to each other and which provider type they're generated by. For simplicity's sake, I have left out some of the home care providers, such as Allied Health, but you can imagine how they would really add on to this picture. So first, a referral is made to home care, and that can be done by a service provider, like a primary care provider from the hospital. It can also be done by the client themselves or their family members. And so the care coordinator then assesses the patient, generates that CCAC chart, and if they are admitted to service, they generate the service referral. So the service referral goes out. Now for nursing, a nurse would then go in and assess and admit the patient, generate a nursing chart and a care plan. So that's 2 assessments there, and they're not necessarily the same type of assessment. So we had talked a little bit earlier with some people about, does the CCAC assessment go to the service provider? In some cases, yes. In some cases, no. In some cases, there's a summary of that assessment. And all in all, though, the nurse will do their own assessment when they go into the home to see the patient. Also for the PSW care, so for personal care, an assessment is done, the patient's admitted, and a PSW chart and care plan is generated. Again, same thing goes with that. You may get the CCAC RI assessment, you may not get that. Either way, there's going to be another assessment done of the patient. So then the care provider documents their daily care in their individual charts. Nurse in the nursing chart, PSW in the PSW chart. At regular intervals, or if there is a change in status, the PSW will update the PSW supervisor about the status of the patient. And then the supervisor will then update the care coordinator via the required reports, phone communication, those kinds of things. The nurse can update the care coordinator via the required reports and phone communication directly. And then the care coordinator uses that information, completes repeat assessments, adjusts the service plans, or discharges the patient. Then all that's fed back to those two services. So you can kind of see the loop and how communication happens here and how those records relate to each other. They're all kind of in parallel, but none of them are integrated. Okay. So as illustrated by the focus group quotes on the slide, when the documentation was accessible, nurses found that the formatting of PSW charts were inadequate to inform their clinical decision making. One of the nurses said, if we go in and see a client, it's another agency that's doing PSW, we can look at their chart. The problem with that is that a lot of times they're tick sheets. They just tick them off. It's hard to see that on that tick sheet what they've actually seen. Did they notice redness earlier? Did they report it? It's not actually documented in their charts. And for the PSWs, they didn't really feel like anyone was utilizing their documentation, so they kind of had the, what's the point? Like, why am I documenting this? So the nurses aren't, one PSW said, the nurses aren't really going to go into our chart and look because they're looking in their own charts to see, but we might really have some important stuff in our charting that they don't know about that we've been logging for the last week or two. So it's actually kind of funny because those two were very related and they were from completely different areas and different agencies. So now we're going to look a little bit more deeply into the documentation of added skills to go along with this theme of documentation. As Erin outlined in the first presentation, added skills are those tasks that are performed by PSWs which are outside their education and which require teaching assignment or delegation by a regulated health professional. Basically, how the process goes is the patient's admitted for supportive care services, their care needs are assessed, the need for added skill is identified, and added skills taught and assigned, and the PSW and patient care needs are monitored. The majority of that is done by the PSS supervisor, but also additional tasks could be identified by the CCAC care coordinators if they know in advance. So there are two different ways that the need for an added skill can be identified. And this is just a review, but this is the difference between delegation and teaching assignment. The delegation is that formal process to transfer the care activity, which is a controlled act, from a regulated health professional to someone whose scope of practice or education doesn't include the controlled act. The assignment of patient care activities that are outside of the scope of practice of an individual but don't require formal delegation are typically called teaching and assignment. But what we need to remember with teaching and assignment is that they're still outside the education of a PSW, and they do still carry a higher risk than what that typical education is. And so the teaching and assignment piece is still quite important. It's just not as formally documented. So now, coming back to this slide, we're going to examine two structural issues that are impacting the delivery of added skills. And this one is a little more complicated, so I might need a little extra notes here. So as previously highlighted by the quotes from our focus group participants, the lack of connection between the PSW and nursing documentation has been identified as a barrier to providing safe and consistent care. These providers are essentially delivering care and documenting in parallel rather than complementing one another as a team. For the most part, there's little, as Erin said, communication, if any, between the providers, which makes it difficult for the PSWs to provide any kind of meaningful clinical input into the care that the nursing team is providing. Additionally, the nurses who have that established therapeutic relationship with the patients, they don't actually get to support the PSWs who are providing care to the same people. Now, oh, that's going to drive me crazy, this clicking thing. Just move on, here we go. So I'm going to do an example. So in regards to the delivery of added skills, the lack of integration between PSW and nursing providers can be an issue, especially if like we said before, the supervision ratios are high and supervisors are only able to see patients for annual or biannual assessments. Monitoring and evaluation for the need for added skills or even for changes in patient status can be, sorry, going too fast apparently, can be kind of pushed back to deal with all those incoming admissions. And so the PSW, if they identify a change, they have to update the supervisor about that change. So for example, if a PSW identifies a spot of potential skin breakdown, the PSW informs the supervisor, who then communicates with the care coordinator. The care coordinator relays the need for a nursing assessment to the nurse, who then reassesses the patient and adjusts their care plan as necessary. They may be adding on wound care or maybe looking at an infection, but basically then they're going to go back and communicate back to the care coordinator, who's going to adjust the service plan. And then they have to communicate back to the PSW service plan, who adjusts their care plan as necessary, who then tells the PSW what to do. But in that time frame, maybe that spot has gone from being a little red spot that's stage 1 pressure ulcer to actually becoming a pressure ulcer, or maybe that infection that was developing has gone from, you know, a light cellulitis to a much more severe situation. If they could just communicate here, maybe we would be able to eliminate some of that communication loop and the need to go back and forth to adjust service plans. The second issue that we're going to talk about related to structures is found in this part, where the PSW supervisors assess and admit the patient and generate the PSW chart and care plan. So often PSWs, as Erin said, are the first providers to see the patients, with supervisors completing their home visits, in some cases up to a month after they've been admitted to service. And according to one focus group participant, what will happen is the PSW will be the first one to go in. We usually don't get in within the first week or two of service in a good world. In this time, there may be no formal care plan, or the care plan that is developed by a conversation over the telephone, or it's coming from the referrals from the CCAC, who again may have done that assessment over the phone. So no one's actually really seen the patient other than that PSW who goes in to see the patient for the first time. So there may also be added skills that need to be delegated for that patient, but it hasn't been documented. So basically, what the PSW supervisors had said is that a patient may need a special function right away, but everyone just generally accepts that it may take 2 or 3 weeks to coordinate that special function. And by the time that the training actually occurs, this patient has gone a week or 2 weeks without these special function exercises, or their Hoyer lift done and it's sitting in the corner, or the family's been doing it. And so these kinds of delays actually have some pretty significant impact on both the quality of the patient care that we're able to provide, as well as the patient, the family, and their level of stress and what kind of care they're having to provide. Again, probably without any teaching about how to use that Hoyer lift or how to do those exercises, other than when they were in the hospital or under a little bit more duress. So now that we've looked at some of those structural issues related to the delivery of added skills, we're going to move on a little to documentation. And so the College of Nurses of Ontario state that delegation can be either oral or written, but however, the appropriate documentation of the particulars of delegation must be maintained. And this includes documenting the date of delegation, the delegator, the delegatee's names, and the conditions applicable to the delegation. When it comes to added skills that aren't formally delegated, the documentation is a little bit less clear. And so I wasn't really able to find any particulars about what needed to be documented in teaching an assignment, and other than from the algorithm that tells you whether or not you should be teaching or assigning things. that they needed to identify the conditions for performing and indicators for seeking assistance and ensuring that a monitoring mechanism is in place. And so when I wasn't able to find it here, I also went out and looked in some of the other ministries and colleges across Canada to see if anybody else had a little bit more detail about what needed to be documented. And again, it was pretty vague. It was more along the lines of talking about appropriate documentation rather than actually saying what needed to be there. When we reviewed organizational policies through the jurisdictional scan, though, we found that most organizations did really have clear policies and/or forms relating to the documentation of added skills. Most of the forms contained these key pieces: step-by-step instructions on how to perform the skill, conditions for performing the skill, indicators for when to seek assistance, and signatures of all the regulated professional teaching the skill and all PSWs who receive the teaching. In some organizations, there was also information regarding the frequency of ongoing competency monitoring and signs of client progress that the PSWs can expect. However, when we did the chart review, these forms were not regularly seen in the patient charts, and nor was there any information found in progress notes. The location of the information regarding which PSWs had received training varied, with some organizations keeping a record of which PSWs were trained in the HR records or their scheduling systems to really facilitate scheduling to ensure that the people that were going in were trained. But depending on what the purpose of the documentation is, and if you look at the fact that it has step-by-step instructions, conditions for when you should be appropriately doing it or not, and what signs and symptoms to be looking for, most of the policies said that it was supposed to be in the patient chart, available in the home for the people doing the teaching or the people who are performing the skill. And so in the charts that we looked at, there was some documentation of teaching or delegation of an added skill in 12.9% of the charts, and that could include either just a one-liner in the progress notes saying that the skill had been transferred to the PSW, or no documentation of teaching or delegation at all in 87% of the charts. And so we did have 210 charts that had added skills in their care plans. So why? So like Aaron talked about, there is variation in policy regarding which tasks require formal delegation, which tasks require teaching and assignment, and I don't know how much of that policy level information is really getting down to the people actually providing service. And again, like I said before, the HR scheduling records versus the patient charts, what is the impetus for documenting? Is it so that we can make sure that the people who are going in have the skills, which I think is very important. We didn't have access, obviously, to HR records for ethics and all of that piece. But maybe it should be in two places. Again, double documentation, but that's just. So before I report findings from our chart review data around outcomes, I just wanted to provide you with a quick overview of the characteristics of our sample. And so, as Anne said previously when describing the methods, our sample included 774 unique patients from across 4 CCACs and 6 provider organizations. So that 774 patients meant that basically times 3, we reviewed that many charts. It was fun. So the mean age of the patients in the sample is 80.5 years. 61% of them were female. 39% of them were married, and 88% had a caregiver. 25% of our sample lived alone, while another 25% lived with their spouse, and 22% lived with their family, which could also include their spouse. It just meant that they had more people living in the same household. And finally, 28% lived in congregate living settings like retirement homes, group homes. I think that's it. Assisted living, yes, good one, yes. And so the patients that were in the sample received a really wide range of services. Next, I'm going to examine 4 of the most common service patterns that we saw in the sample. So this graph depicts the percentage of the sample in each of the 4 most common service patterns. The blue bars represent patients that are in that pattern that received a low frequency of PSW service, so that's 1 to 2 times per week. The yellow bars represent the patients receiving a high frequency of PSW service 3 times or more a week. So you can see that there is a lot of people in the PSW, allied health, and nursing group. So these are the people that are more complex. They're receiving higher levels of PSW services. And what's the point of this slide? Why am I telling you this? Well, the main point of this slide is that in our current system, multiple services equal multiple service provider organizations. So as Erin said before, you may be receiving PT, OT, nursing, and PSW, and you may be receiving them from 4 different organizations. So there's little communication that's happening between those organizations, and there's no sharing of documentation. So now, related to that idea of multiple providers, we will be looking a little bit more deeply into the issue of continuity of care, specifically examining 2 dimensions of continuity. Oh, is there a question?
I just
Sorry.
wanted to ask whether or
Missed
not
that.
in your sample, if
Yes.
there were any regions that have a CCAC that's moved to the geocoding where they've actually tried to reduce the number of agencies that are delivering multiple services. Was that in your sample?
I've never heard of this. So it may be in my sample if you tell me which CCACs, but...
So I'm from the Southwest, and our CCAC has done a lot of work over the last number of years for areas where they have the ability to leverage one agency to do, say, nursing, PSW, and some of the therapies, that they've geocoded that agency to deliver all of those services in a particular area.
That's lovely. No,
To reduce that phenomenon.
I don't think so either, but I can ask the people later and get back to you. Yes?
Champlain has a similar thing, but again, it's even within one agency. I think the issue with the charts remains. So it may be, Bayshore has therapies and PSW and nursing, but it's still major charts.
Yeah, thank you. Okay, so there are 2 distinct dimensions of continuity which we will be discussing in relation to the delivery of home-based care. So there's interpersonal continuity and organizational continuity. And interpersonal continuity is defined in this study as continuity of the individual care provider. This aspect of continuity is important for building personal trust, therapeutic relationships, developing knowledge about the patient routines, health conditions, and care needs. Organizational continuity in the study was defined as continuity of service provider organization, both within an episode and across episodes. I shouldn't actually say episode, across admissions. So there are people within this sample, which we'll look at a little bit further on, that went in and out of nursing care or in and out of PSW care during that year while they were admitted to home care. So home care as a big piece. And so we are looking at both the service provider organizations within the full 1-year episode of care and across those multiple admissions. And organizational continuity is really important for both informational and interpersonal continuity. So the interpersonal continuity we already talked about. The informational continuity is the piece around having the documentation from previous episodes of care, really knowing what happened to that person before. Some really important aspects of that would be knowing what someone's baseline is and being able to know if they're moving back towards that point, because if you're always just seeing them at the beginning of an episode, you don't know what they were like before, if they came from hospital especially. And so having that history of records is more what we're talking about for informational continuity. So when examining the number of PSWs providing care, we really wanted to be able to account for the increased number of caregivers related to frequency of visits. We're aware that due to scheduling, the same person can't provide all 3 visits if they're being seen 3 times a day. Like, it just doesn't work. And we actually did have people in the sample being seen 6 times a day. So again, we know that there's going to be more providers for people who are receiving that intensity of care. So we broke down the analysis into the frequency patterns that we saw most often within the chart reviews. So the 6 that we saw most often were the 1 to 2 time per week people, which I like to call the bath and laundry ladies, which is what everyone else in the study referred to them as. The 3 to 6 times per week people, the people being seen daily, 2 times a day, and 3 or more times per day. And so what this kind of graph is, for anyone who doesn't know, this is a box and whisker diagram, and the blue boxes represent the 25th percentile and the 75th percentile. So half the sample's in that blue box. And then from the bottom and the top of the whiskers is the minimum and the max. And so some people argue with me about this slide and say I should be excluding outliers. And I shouldn't be putting in that person who saw 25 different providers when they were being seen 1 to 2 times per week over a 3-month period. But what I have to say is that's a real person, and that is the reality for somebody. And so even though that is an outlier, how is that happening? So I did want to include all of the information because, like I'm saying, how patient-centered can our care really be if you're seeing 34 different providers in a 3-month period? And how much can those providers know about you, especially for our patients with dementia or other cognitive issues, where you really need to know about their routines and they need to know who you are. If you have 34 different people coming in, you're going to end up with some behaviors and potentially other issues. Now, organizational continuity. So for this, we broke it down into 2 different components. The number of service providers involved in care over the episode, like I said, and the number across admissions. So this one's about the episode. So the average number of service provider organizations ranged from 1 to 7, with an average of 2.5 per patient. One thing I think you were going to mention, but you didn't actually mention. So for the people who received 1 provider, only 5.7% of our sample who had both PSW and nursing received care from the same provider. Only 5.7%. And like Claire had brought up, even though they are receiving it from the same care provider, are they sharing charts? We don't know. So yeah, we have 15% of people receiving care from 4 or more providers over that 1-year period. In this slide, we examine the portion of patients who had multiple nursing admissions over their episode of care. These patients typically receive short periods of nursing care for an acute issue, are discharged, and later come back onto service either for the same issue or a different issue. This largest pie over here represents the total number of patients in the nursing sample. And so you can see the green is the 1 admission. So the majority of the patients are, only there for 1 admission. But that blue section is people who were admitted and discharged and came in twice. So they had 2 admissions. And of the people who had 2 admissions, 70% had their care from different providers. And then this bottom part here, the yellow, that's people who had 3. And of that pie, now I forget, 0% had it all from the same service provider, and 13% had 2 of their 3. No, that's not right. Yes.
So in this, was there any analysis of the type of nursing intervention that was involved? Because if somebody goes from a wound care to a palliative, if it's a different type of wound, if it becomes some sort of different service, I mean, in a perfect world, yes, the same person would know because they would get to know the whole person. But I think a number of our agencies would argue that they're going in for
A specific.
nursing clinical specific intervention, not as holistic as maybe it could be, but so it matters, but does it matter if it's a different focus of the nursing?
So I was really hoping someone would ask that question, because we did actually delve into, especially the people who saw 3 or more different providers, and the sad fact is that the majority of these people were originally admitted for pain and symptom management or wound care, and were subsequently admitted for palliative care. And so I would personally argue that these are the most important people who go from pain and symptom management to palliative care, that they would have continuity of the service provider organization from that transition. And I mean, we weren't sure if there were still palliative contracts or IV fluid contracts or dialysis contracts, or that I didn't get a chance to ask anybody about that. And I would argue again that maybe shouldn't be the way that we're structuring care. It's not very patient-centered, and I understand that maybe you think that those pieces don't relate, but oftentimes they do, especially when you're talking about IV therapy and maybe wound care, because people who are receiving IV therapy, maybe they're receiving that therapy because they had a cellulitis from their wound. Or if they're receiving diabetic care and wound care, those things are very related. And so to break them apart into tasks really, I think, demeans the quality of our nursing care, and it really brings it down to a level of task-based care, which in the community I don't think we can do. Yes.
Was there the ability to understand how much of the multiple service providers across admissions was driven by our current constrained contract management system?
There is not. I would like to know that piece of information. One thing I should also say is that a very small portion of those people also were getting concurrent service, so they were admitted to 3 or more times. I think the maximum admissions we had was 5. For which we actually put into the database, but I think there's actually 5. And that was around not one agency not being able to provide all of the care. And I mean, that is also a huge problem for me, because if you're only coming in on weekends and someone else is providing care all week and you have no access to their records, what do you know about what care was being provided during the week?
Yeah, and the other, and I absolutely agree with that, the other difference would also be there are contracts that are for instance, palliative shift only.
Yes.
So if they
Yes.
move to that might be a contractual shift, which in the perfect world wouldn't be.
Right.
But yes, we're dealing with no new contract
Yeah.
issued since before '07.
Totally.
Before '08.
Totally understand that, and definitely some of those people were in that exact situation where they switched to shift nursing, palliative shift nursing. But again, previous arguments all stand for that. So, focus groups also identified continuity of care as having an impact on the delivery of added skills. One care coordinator highlighted the reality of the current environment, saying that I think that we have to look at the environment that we're in right now. It's not consistent, reliable, dependable support workers in the community. And a nurse from another focus group really emphasized the fact that the personal support workers needed to be trained on the skills. So these skills, you needed to be trained on them, not necessarily eye drops every time, but some of the other ones, because of the high turnover rate and having different people with days off, and so-and-so's covering this day off, but they're not trained, it makes it a lot more difficult. And so what I wanted to say about this was that we really actually start to lose some of, and if this is the argument, I'm just putting it out there, we start to lose some of the cost effectiveness of putting PSWs in to do some of these delegated tasks if we're training and retraining and retraining and retraining people. And if we have to do these additional visits for the PSS supervisor to go in to teach 8 different people this transfer technique. I mean, those are both related to the continuity of care, as well as some of the other issues with PSW workforce at this current time, but yeah, but yeah. So to summarize, why is continuity important? Continuity is really important in home-based care because of both relational and informational continuity. The relational continuity is really strengthened when patients are able to have the fewest number of providers possible so that they can build therapeutic relationships and develop and deliver patient-centered care. And the informational continuity is really important for the availability of patient-related clinical information about changes in status, health events, and in order to be able to communicate between providers. Like you said, in a perfect world, even if we were providing all of the care from one organization, it doesn't necessarily mean that they are communicating across the organization, but at least the opportunity's there. At least, you know, you can check in with the PSS supervisor from your own organization. You can walk across the hall.
Could you go back?
Yes, I can.
I'd like to suggest, and I know it may not sit well with you, the academic world, that the second bullet should be your first bullet. And borrowing a phrase from the Clinton era and presidency back in the early 90s, I'd say something like, because it's patient-centered care, stupid. You know?
Yep.
Really, why is continuity important?
Patient-centered care.
Patient-centered
You're right.
care, stupid. And then the rest of it.
Totally agree.
The other point, if I may, I just want to make this quickly. You begin to see the pattern of development at 2 levels. And I know we're going to talk about this later.
Mhm.
In modernizing the contract piece in Patients First,
Mhm.
you see the link between your results and how important that is.
Mhm.
How that is designed will be more fundamental than any restructuring, because that hits the patient, their family, and other caregivers.
Mhm.
The second is, until we get to a technology-based solution and platform for tracking
totally agreed. We get told all the time that we're flogging a dead horse about one patient chart, but I'm going to keep doing it until it happens. Okay, so I am really behind, aren't I? No? Oh, good. Okay, so now we're going to move on to the last portion of the presentation, the home care outcomes. And the outcomes were chosen, that we chose to measure in this study were carefully chosen with consultation with our home care agency partners. Today we're going to highlight results for all of the outcomes measured and then really look into an issue of outcomes reporting that I just wanted to bring up at the end here. So these are the 10 outcomes that we looked for when doing chart reviews. So the 6 clinical outcomes we looked at were falls, new wounds, medication errors, catheter obstructions, caregiver burnout, and death. And the service use outcomes were emergency department visits, hospitalizations, crisis long-term care applications, and long-term care admission. Yeah, that's good. So for each outcome, only those patients at risk for the event were used to calculate the event rates that you're seeing here. For example, only those who have a catheter can experience a catheter obstruction, and similarly, only those with a caregiver can have caregiver burnout. All patients were considered at risk for falls, new wounds, medication errors. Actually, that's not true. If they didn't have any medications, they weren't considered at risk for medication errors. No, let me change that one more time. Only people who were on service for medication management, medication queuing, medication reconciliation, or something else medication related were considered at risk for medication errors. Sorry. Everyone was at risk for new infections. I already talked about catheter obstructions and caregiver burnout, and everyone was at risk for death. Death was only considered an outcome here if they died either unexpectedly at home or in the hospital. We can't account for people who died after being admitted for longer than 14 days because they are discharged from home care services if they're in hospital greater than 14 days. So if they were admitted to hospital and then died later, we don't know about those people. And we didn't include people who died either in hospice or in at home with a planned death at home certificate or obvious documentation that that was their plan. So, right, just had to remember what my colors were for. So for falls, of our sample, the ones in blue are people who had one event, and the ones in orange are people who had multiple events. And so you can see from there that about 40% of people in the sample had at least one fall, and 23.3% of those people had multiple falls. For new wounds, same thing. You have a little bit over, I think it's 22% that had a new wound during the admission, and 9.4% of those people had multiple wounds during their admission. 3.7% of people had medication errors that were documented. If there was a medication error and it's not documented, we don't know about it. And that goes for all of these outcomes. If they're not documented, we don't know, but these are all documented events. So new infections, there were 28.6%. I can do math on the fly. 28.6% of people had a new infection, with 10.4% of people having multiple infections. Catheter obstruction, 16.1% of people with catheters had an obstruction, at least one obstruction. Caregiver burnout, 18.3% of people had documented reported caregiver burnout on their chart. So that would be either the nurse, the care coordinator. I don't think I saw it in PSW charts, but the nurse or the care coordinator writing that something about the caregiver saying that they're burnt out, saying that they need more help, saying, it was pretty obvious documentation. And death is pretty self-explanatory. 17.3% of the sample died within that year. You?
For caregiver burnout,
Yeah.
is it one documentation of caregiver burnout gets you 18.3, or if there was multiple indications at different times that again did it rise to a?
We didn't actually record. It was a checkbox whether or not caregiver burnout had been documented. There were definitely charts that had multiple documentation of caregiver burnout. A lot of those were around some of our older patients who were caring for a spouse with dementia. I think that's probably the biggest ones, people who needed 24/7 care and were still in the home. A lot of them went on to crisis lists. Yes?
If I may look at, is
Any report of a fall while they're on home care service, yeah. It doesn't necessarily have to be that they fell when the PSW was there giving care, although there were lots of reports of those as well. And I mean, falls, as everybody knows, is highly underdocumented because a lot of, especially elderly patients, don't want to report falls because they don't want to be sent to long-term care or feel like they can't live in their home anymore. Yeah. Yes.
This may sound like a very funny question.
Okay.
But is death a clinical outcome? Or are you reporting simply that in the course of the year, 17% of the folks died?
17% of the folks died. The reason we have it under clinical outcomes, and I mean, you're right, it's not really a clinical outcome. It was one of our end-stage reporting outcomes, though, was these were people who were unexpected death. These aren't people who are palliative at home and you're waiting. You don't have documentation of them being either palliative status or planned death at home or going to hospice. Any of that. It's just people who died while on service. Okay. Service use outcomes. So this one's a little bit busy, but here you'll see 66% of the sample had at least one emergency department visit over the course of the year. And of the 509 patients with ED visits, approximately half of them had multiple visits. You can see the legend along the bottom. I don't know why it's reversed. I couldn't fix it. I'm sorry. But the green at the top is the six or more events, and then 5, 4, 3, 2, 1. Same goes for hospital admissions. 58.5% of this sample had at least one hospital admission, with a large percentage also having multiple admissions. 13% of the sample was designated as a long-term care crisis during their admission, and 18% went to long-term care. And just because you were designated long-term care crisis does not actually mean that you were the people who went to long-term care, because some of the people who were designated crisis ended up hospitalized greater than 14 days, or they died on service. Yes?
Was there any attempt to look at the hospital admissions, presumably through ER, emergency department?
Through the ER.
Yeah. How many of those might be avoidable with certain interventions, and the resultant impact down the food chain to the ALC issue that we face in the program?
So unfortunately, we haven't been able to do that analysis yet. We do have the reasons for hospitalization for every one of the hospitalizations. And I don't know that we would be able to look at what the impact was on ALC. But yeah, I would love to be able to do that. I don't know that we would be able to do that with the data that we have. Sorry, Tom just had his hand up.
I can tell you H&H3.
Yeah.
You'd be able to find out the impact on ALC. We have that continuity data.
Okay. We can chat. Yeah.
The hospitalizations, are those post-admission to home care?
Yes.
Okay, so it isn't.
It's not the hospital. No, no. These are all within their episode of service.
I was going to say.
Same question. Yes. No. So, and I mean, the same goes for all the other outcomes that we reported. If someone came on service with a wound, we did not count that as a new wound. If they came on service with an infection, that was not counted in the infection totals. Okay. The one thing that I should preface that is that if they had a wound that they came on service with and it got significantly worse and it required additional intervention, then that was counted as a new wound. That only happened in like 3 cases, I think. So this is my last slide, so I'm not doing that badly. And so this slide, through our review of the multiple records, we were able to synthesize a patient chart, which contained all of the information reported to care coordinators, nurses, PSWs, caring for the patients in our sample. As we previously stated, the outcomes were compiled. I don't know actually if Anne ended up saying that part. But so the outcomes were compiled from across the charts with data checks including the reason for care and the date of the event to ensure that they were unique events. So we wanted to make sure that we weren't double counting things. If they were even within a day and they were very similar reasons for care, then we assumed that it was probably the same one and it was just someone had reported it and documented it a day later or 2 days later or something along those lines. But I'm going to go to my, 1 minute, thanks. Whoop. we were very lucky because we were able to compare the events documented in the patient records with the events that were reported in administrative records to the LIN in one of our CCACs. I didn't know if I was going to say that. But, and so this is the results of that analysis. And so basically, ED visits were overreported in chart data 5.6% of the time. So there was a record of it in the chart, and there wasn't a record of it in the administrative data from NACRS, so from the database. However, they were underreported in chart review data 41.4% of the time. 41.4% of the time. Hospitalizations, yes?
No, is that because of documentation, or do you think that they really didn't know? Like, George went to the hospital.
A little of column A, a little bit of column B, maybe. We also actually have, and I haven't been able to do analysis on it, the location of which chart all of the events were reported in. So we can see, you know, what event was reported in a CCAC chart versus in a nursing chart versus in a PSW chart, and when that event is actually reported in all three, which was few and far between. Do you want me to stop? Okay. So, I mean, I can't really say. I don't know if it's because they really didn't know. Most of the times when we got these kinds of ED visits and hospitalization data, it was a really quick little note that just said, so-and-so returned from the hospital. I am going to be doing XYZ care on them. So it wasn't really documented that, you know, the patient went to the hospital, this is the reason they went to the hospital. Also, in CCAC charts, often holds have to be put on for patients that are in hospital. There were a number of charts where holds were not put on when patients were in hospital. And so, I mean, it's very difficult, especially for the CCAC. Not only does somebody has to call them and tell them, essentially, that they're in hospital or they went to the ED, right? So it's not the same as if I went in there as a nurse and I talked to Joe and I said, hey, Joe, how are you doing? Oh, well, I was in the hospital last night. I'm going to write it down. Then I have to go and call the CCAC, or Joe has to call the CCAC and tell them, and then they need to document it, and then they need to put that person on hold if they need to be on hold. So there's a lot of communication issues around how events get reported, and I guess the question is it important? For me as a nurse, I would want to know if my patient was in the emergency department, if they were seeking care, you know, from even urgent care. I'd still probably want to know, because there's obviously something going on that is going to impact their home care services. Yes.
Just want to say, so for the nurse at the front line, so we're in a region where we have an electronic ED notification between the and the hospital. However, that's great. It goes from the hospital to CCAC.
Yep.
But getting
That doesn't
it from
go.
the nurse record to the nurse or the PSW
Yeah.
is a whole nother matter.
Yeah. Totally agree. At least somebody knows. You're stepping it up a notch. At least somebody knows that that person's been to the ED or to the hospital. But I totally understand. Like, that's an extra piece that needs to be communicated. And I mean, that goes back to all the same things that Erin and I have been talking about with the back and forth communication and where things are actually feeding into each other. Because really, everyone in the home care team needs to know that. Whether it's the PSW providing care, or it's the nurse, or it's the person who's doing care coordination, and they need to maybe up the service because, you know, their intensity is higher because they had a stroke. Like, that is actually one that was not documented, stroke. Like, I think people need to know that. And obviously, they probably do know some of it, but it's not reflected in the charts. And so a part of it is going to be whether or not it's documented or not. And that's all we can really do with chart review data. And it's a limitation. Yep. And it's actually my last slide. So that wraps up our presentations for this morning. Lunch is going to be served in the kitchen now. After lunch, we're going to be heading to our discussion groups. Your assigned discussion group is color-coded on the back of your name tag. For those who are in the blue group, you're going to be back in this room after lunch, and those in the red and yellow groups will be in the rooms on the second floor. We actually put up signs directing you which direction the two rooms are. I am leading the yellow group, and Erin is leading the red group, so also if you just want to come down with us, we can take you